Welcome to the Parkinson's Foundation Wellness Wednesday webinar. Today we return to our palliative care series where we will share things to know about hospice care for people living with Parkinson's disease. I'm Krista Ellis, Community Engagement Manager for the Parkinson's Foundation. Helping me behind the scenes are my colleagues Jenny Fearday and Laura Cameron. Please share in the chat where you're joining from today and say hello to your Parkinson's community. I'm joining you from Cincinnati, Ohio. We are recording today's presentation and you will receive a follow-up email from us with a link to today's recording and other resources in the coming days. Again, we are recording today's session. If you want to revisit any of the information that we covered today, you will have access to the recording in the coming days. Before we begin the formal webinar, I would like to share a little bit about the Parkinson's Foundation. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Everything we do is in close concert with our community to ensure that our actions are aligned with the needs and priorities of those living with PD. We are focused on improving care for those living with PD, advancing research toward a cure, and empowering our global community. Today's program is a great example of one of the things we are doing to help us meet these goals. One example of our mission in action is PD generation. This research offers genetic testing for PD-related genes and genetic counseling to people with Parkinson's at no cost. Commit to helping us advance Parkinson's research today. Check your eligibility and enroll now to be a part of PD Generation at parkinson.org/PD Generation. If you're looking to get more involved, we're excited to share our initiative meant to capture the community's perspective on various topics in Parkinson's disease. We hope that you'll join us by signing up for this initiative where we invite you to complete a 10, maybe a 20-minute survey on various topics such as mental health, telehealth, palliative care, and certainly for our care partners. We will always report findings back to the community. You can learn more at parkinson.org/PF surveys. We'd like to take this moment to thank PCORI, a patient-centered outcomes research institute, for their implementation award to support our palliative care series. Thank you, PCORI. PD Health at Home is presented by the Light of Day Foundation. We also want to take this moment to thank the Light of Day Foundation for supporting the mission of the Parkinson's Foundation. The Parkinson's Foundation provides weekly educational and wellness programs virtually through our PD Health at Home programs, including Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. As a reminder, all programs are held at the same time, 1 p.m. Eastern Time. You can learn more and register for these programs by visiting parkinson.org/PD Health. As we close announcements, we settle in to explore the things to know about hospice care for people with PD. During this session, we will provide an introduction to hospice, explore what hospice is, the types of services hospice provides, and the typical timing of hospice. We will also discuss how to select a hospice program that can best fit your needs and how to be an advocate to receive the types of services you need. Following the conversation, we will have a live Q&A session. Thank you for joining us today and having this conversation with myself, Dr. Daly, and Stuart Waterstone. We'll see you guys for the live Q&A just after the video.
My name is Farrah Daly. I'm a neurologist and palliative medicine specialist in Northern Virginia. I've also been a hospice medical director for more than 12 years. I have seen hospice care be a great asset for people living with advanced Parkinson's disease and their families. I have also seen that many times people are unsure of what to expect from hospice care, or they don't know when to access the services. I'm going to describe 5 things that are important to know to have a good basic understanding of the hospice system in the United States. The first thing to know is that hospice is about support and resources. It is a team-based approach to care that is intended to empower a person and their family to live well until the natural end of life in their desired location, which for most people is their home. The team of care includes a number of people. First, and most importantly, there's a nurse who does regular medical checks and communicates with the rest of the team. There is also a physician who can make medication adjustments or provide education and counseling. There are volunteers who can help with a variety of different tasks depending on what is needed. There's social work and spiritual care to help with emotional and spiritual support. And there's bereavement support provided to the family for at least 1 year after the time a person dies. In addition to the team-based medical care, hospice also provides equipment to make adapting to changes at home easier and medications to improve day-to-day quality of life. In addition to these core services, hospice may also provide physical, occupational, and speech therapy for some targeted symptoms. They may provide complementary therapies like massage or music therapy. And they will provide certified nursing assistants who can help with hands-on care like bathing. There is still a lot of work for the family to do, but regular visits from different team members ideally have the family feeling supported in times of need and make care at home possible when it otherwise might not be.
Yeah, I had wonderful people that were coming. Yeah, and that's something else I encourage people not to wait on. If somebody offers it, grab it. The nurse that came, she'd come a couple of times a week. There was a CNA that came, and you know all this stuff. All the people that come and help you. So they were really attentive. The nurse she was really good. She knew what she was doing, and I could talk with her. She was really honest with me. And I appreciated that. I don't want somebody to make it rosier than it is.
The second thing to know is that hospice should provide an individualized and personalized care plan that's specific to a person's goals and situation. When a person begins hospice care, you can expect that the medication list will be reviewed and carefully considered to make sure that every medical treatment is aligned with what's important to that individual. Expect to continue medications that improve function or quality of life or comfort on a day-to-day basis. A good example in this category for someone with Parkinson's disease would generally be carbidopa-levodopa. You could expect to stop medications that are purely preventative in nature, such as a cholesterol-lowering medicine. Then there are medicines that are in between that may be helping somewhat, but are also providing some significant side effects. These medications will be carefully analyzed to make sure that they're causing benefits more than that they are causing harms on a day-to-day basis. In addition, medications that are particularly expensive, such as pimavanserin for hallucinations or droxidopa for low blood pressure, these will be considered carefully because the hospice becomes financially responsible for providing all of the medications. And so they may continue to provide these medications, but they're going to want to understand whether other medications have been tried first and whether these are really providing a significant benefit to warrant the cost. It will be helpful if you have that information, or if you can have your neurologist have a conversation with the hospice team about why your medications are important to your quality of life. Sometimes a hospice cannot provide an expensive medication, even if it is contributing to your comfort and quality of life. In this case, it would be important to discuss with your neurologist or primary care provider what your options might be. The third important concept to understand is the timing of hospice care. In the United States, the availability of hospice care is defined by regulation and legislation. Hospice is only available to people who are probably within the last 6 months of life. Also, to people who are no longer seeking curative treatment or for whom a cure is not available, and people who choose hospice care. That means no one can be forced to use hospice care. It's always a choice. So a bit more about the probably within 6 months of the end of life. The actual language is that 2 physicians certify that a person is likely to be within the last 6 months of life if the illness continues on a typical course. So you hear the uncertain words there, likely and if the illness continues on a typical course. This is because there is a lot of uncertainty in predicting how long someone will live in advanced neurologic illness. We are not able to do this with perfect accuracy or even with really great accuracy. And so we rely on some specific signs that indicate that someone may be approaching the end of life, but we're never really sure. The signs that we look at that mean someone may be possibly within 6 months of death include a very low functional status, which means generally not walking, bedbound, not talking much or talking very little, and incontinent of bowel and bladder. And then in addition to that very frail state, they are also having several complications related to their illness. Those complications might be repeated infections like pneumonias or bladder infections, weight loss, repeated trips to the emergency room or hospital, or a rapid loss of abilities. Any one of these signs by itself may not mean very much, but when several of these things are starting to happen together, it is a warning sign that somebody may be approaching the last months of their life, and then they're eligible for the added support of hospice care. Now, sometimes people take that information and think that hospice care has a hard limit at 6 months, and that is not true. Care can continue for longer than 6 months as long as it remains appropriate. Hospice has a process to reevaluate if a person is still eligible for care, because remember, there is a lot of uncertainty. We can't predict things with 100% accuracy, and the system understands that. Hospice reevaluations occur 90 days after starting hospice care, 180 days after starting hospice care, and then every 60 days thereafter. So each time, the hospice medical director is reviewing the situation to see if they, in good faith, could still say that they're expecting the person to be within 6 months of the end of their life. Sometimes people can even improve with hospice care and are no longer eligible to continue. In this case, the hospice care stops and the regular insurance benefits resume. Now, that's not very easy because equipment that the person has been using may need to be returned or changed out to equipment that's obtainable through the regular system. But it's important to know what might happen in that regard. And we will talk a little bit more at the end about why this is a particular issue in Parkinson's disease. Now, even though hospice care can continue for longer than 6 months in certain situations, it's important to also recognize that care for most people is actually much shorter than it could be. Most people get hospice care for only about 3 weeks, even though they should be able to get it for up to 6 months. There are a variety of potential reasons why hospice care tends to be so short. Many times it's because in the medical system, we want to be sure and certain that someone is actually approaching the end of life. And as I have already discussed, we're not that great at that. And so if we're waiting to be sure, we will often wait too long. We also sometimes just avoid talking about death, and that leads to a delay. Getting hospice care too late does cause problems. In that case, the team doesn't really get a chance to move from getting to understand your situation or even just greeting you and gathering information to actually supporting you or problem solving the issues that you're having. It can feel like they know you for only a short time and that short time is in constant crisis mode. And sometimes there's not enough time to actually get control of discomfort. In the ideal situation, a family will have hospice support long enough to really get to know the hospice team members. This way, when a new problem happens or their condition changes, the team members are able to be more efficient in solving the problem. And the family already knows who they can trust, and they have less uncertainty. The fourth concept to understand is that hospice organizations can vary in the quality of service that they provide. Every hospice organization is going to have the same basic team structure that I described previously. Every hospice organization is going to provide equipment and medications. However, they may vary in other ways. It's possible that some hospices will support more physical or occupational therapy than others. Some may be able to provide a different amount of nurses' aid support during the week for hands-on care. And some may provide complementary therapies where others don't. Some may have dedicated inpatient centers to manage a crisis that cannot be managed at home, whereas others have to use contracted beds in hospitals or nursing facilities to do this. Financial resources can vary between hospice organizations. Some with robust financial resources may be more willing or able to provide some of the expensive medications that I mentioned before, whereas others may not. Finally, just like any other service organization, there can be variation in the educational level, skill, or dedication of the team members. Because hospice services do vary, if it's possible, before you choose a company, you can try to make an educated choice by checking in with your resources before beginning hospice services. I always suggest that people talk to their family, their neighbors, or their friends, as well as their doctor, to find out who has had a recent good experience with hospice care. You can also use the Medicare website to check survey results. And you can consider asking for informational meetings with multiple organizations before you make a choice. If you have these organizational meetings, it's good to ask questions that are specific to your needs, keeping in mind the medications that are important to you and the additional services that are going to be most helpful to you. Even after you choose a company, it's important to know that you can change your mind. Now that you have the knowledge to know what to expect of a hospice organization, if care is different than what you expect, you can speak to administration within the organization and ask why care is different than what you expect. It's possible that there will be a misunderstanding or that there will be a service correction that needs to be made. If you've tried this and the care is still not meeting your expectations, it is okay to change hospice organizations. This is not necessarily easy because along with changing the organizations, you will also need to change equipment or anything else that they have provided, but there are some times where this is necessary. You can also change your mind altogether and decide that it's just not the right type of care for you and revoke the hospice benefit altogether. The last concept that I would like to go over is that hospice advocacy is necessary. Every hospice provider should be providing expert and dedicated care. I've already described some of the things you can do if you find yourself with an organization that's not meeting your expectations. But even when hospices are providing great care, some of them just need more education about Parkinson's disease. All hospice providers should be educated about Parkinson's disease and medications to use or to avoid. All hospice providers should be willing to communicate and collaborate with your neurologist and your primary care physician. The hospice medication benefit may need a restructuring over time. When the hospice system was designed, there were not nearly as many medications available to improve quality of life in all illnesses, and particularly in Parkinson's disease. We've spoken already about how people sometimes have to choose between hospice care or continuing their medications that improve quality of life. And this shouldn't have to be a choice, but it is the reality of the system that people are working with right now. Advocacy over time to improve or adjust the way the medication benefit is within hospice care can improve the system for everyone. Finally, eligibility based on survival time or the likelihood of dying within 6 months might not be the best method of determining a need for hospice care in people with Parkinson's disease. In the early years of hospice care, the majority of people receiving care had cancer. When people have cancer, they tend to have ups and downs in their illnesses, but then at some point, they start to have a steady and progressive worsening over time. If you think back to when I described how hospice can reevaluate a person's eligibility for services at 90 days, 180 days, and then every 60 days thereafter, you can imagine that when someone is unfortunately getting worse from cancer, that on each of those evaluations, there's likely to be a demonstrable and steady worsening. This matches what regulators look for when they are determining hospice eligibility. But if you think about how people change with Parkinson's disease, it tends not to be linear, especially in the advanced stages. People can have events with a big worsening of their function, but then they can have a significant recovery, but usually not back to where they started. There can be periods of long plateaus before another drop in function again. It makes the situation harder to predict. And if you think back to those periodic recertifications, it's possible that there is not going to be a demonstrable linear decline between each of them. This introduces some uncertainty into a person's hospice care because there might be times when they are still overall very frail, but the organization feels that they have to discharge the person because they are not continuing to worsen in a linear way. This is an area that needs additional research and additional resources to make the system work better for people with Parkinson's disease. In summary, as you know, people with Parkinson's disease deserve expert care. You should expect the best individualized, comfort-focused care from hospice. Be informed about what hospice can and should provide, and make sure you have a great team. And finally, understand where the current hospice model doesn't fit Parkinson's disease, so that you can be a good advocate for yourself and also advocate for continued improvement of the system. I hope this information has been helpful. I leave you with a quote from Dame Cecily Saunders, who was one of the founders of the hospice movement, who said, "You matter because you are you, and you matter until the last moment of your life." We will do everything we can to help you, not only to die peacefully, but to live until you die.
Thank you everyone for joining us, and Dr. Daly for that introduction to hospice care while living with Parkinson's disease. If Dr. Daly and Stuart, you would join me, please. Hi, Stuart. Welcome back.
Thank you very much for the opportunity. And Dr. Daly, I want to make a comment. I wish I had seen your video before my wife went into hospice. It's incredibly informative. Thank you.
Yeah, well, I'm sure that everyone is going to learn from your story as well. And I think it's because of experiences like yours that Parkinson's Foundation is recognizing that people would benefit from having this education before they're in the situation where they need it.
Yeah, thanks for sharing that, Stuart. So Stuart Waterstone joins us from the West Coast. Stuart, would you share a little bit about your story and living with Parkinson's disease and caring for your wife through hospice care?
Certainly. Judy was diagnosed with Parkinson's disease 10.5 years ago. And our immediate response to the diagnosis, by the way, on her birthday, it's a terrible birthday present. I kind of suspected that was going to be the diagnosis because she had symptoms quite a bit before she actually was officially diagnosed. Parkinson's, as most of the people who are watching know, it's a degenerative disease, and it sort of goes in a plane where you get sometimes little peaks, sometimes valleys, but it generally you don't get totally better. And what wound up happening was we had arranged for her to have, toward the end of her life, she had an amazing care team, and she was able to be at home. which was Judy was a middle-level manager. She was a speech pathologist by profession, but she also was involved in the health field. And in skilled nursing facilities, she basically was the person who was working for the company providing the services, and going in her area of coverage started in Santa Clara to the north of California, which way up to the north in California, down to San Diego, to the San Gabriel Valley, to Santa Monica, which is an area of several hundred square miles. And she never could do that in one day, I assure you. Because of that, she said, I never want to go into a skilled nursing facility because they all know me and they're going to get even with me for everything I did to them when I had to ding them. I said to her at the time that we would hopefully be able to keep her. My promise to her was, as long as we were able, we'd keep her at home. And that's indeed what we were able to do through the hospice. So for that reason, I'm very thankful to the establishment of hospice, that she at least was able to die in her own environment, in her own home, not in a strange place with strange people taking care of her. As far as the treatment with Parkinson's, she once again had excellent care. She had a neurologist that saw her at least once every month for the entire time of treatment with 7 years, never missing a month. Even during the pandemic, we had several sessions virtually, but she was still there. It was interesting following my cell phone, trying to follow so that the doctor could see her walking. I felt like I was Steven Spielberg with a terrible piece of equipment, namely my cell phone. But in addition to that, toward the end, we were able to get caregivers who were absolutely tremendous and actually really cared for her. So that made the decision a little bit easier. But the decision of hospice, what came along is there was an alternative of either putting her into a skilled nursing facility or putting her entering the hospice program. And what wound up happening was I befriended several of the charge nurses, who are the people who basically are in charge of the nursing staff at the hospital. And I questioned them, what would happen to Judy if she indeed went into a skilled nursing facility, because she'd have to have a feeding tube. In the last, probably month of Judy's life, she no longer had use of her limbs, and they decided that it would be most detrimental to her to be eating, and she would have to go to pureed food. And she also would have to be fed when she was available to feed, because much of the time she was in a non-responsive state. So the decision, I asked them the question, what would happen in a skilled nursing facility? And they said they keep Judy clean. I said, how about therapies? Would there be any? I was looking toward the idea, is she going to improve it all? And they said, well, you really can't do therapy when someone is not responsive, which makes a lot of sense, obviously. And questioning them further, I decided that it would be something that Judy's wishes would not be to go into a skilled nursing facility, aside from the fact she asked me never to put her in one because of the getting even part, but because she really wouldn't be having any medical treatment. It would just be sort of doing palliative care or end stage care at a nursing facility. But of course, they'd have a feeding tube. And Judy had once told me years and years and years ago, when she was first diagnosed, if I ever get to the point where they need to do something like that, kill me. I said, sure I will. I promised her, with my fingers crossed and my toes crossed. She knew I was not going to kill her. She said, well, second choice, take me to Oregon then, where they'll allow assisted suicide. And I said, I don't think you're going to qualify for that either. I said, but I will promise you this, I will make sure that your wishes are followed. And I mean, she did not want to be put into that kind of facility. So we basically chose hospice because it was the kind of situation where we could do what was at the time the best of very difficult decisions. The two choices were extremely difficult, both of them. And I chose the one I did. The most important thing I could think of at the time was I did not want to look at it from my perspective, but I wanted to put myself in the place of my wife. What would she want? Because that was the most important thing, not necessarily what myself or my children would want for Judy. And we obviously did not want to lose her. Judy and I have been married for 52 and a half years when she died. She was the other half of my body. I'm missing about a half of it right now through almost everything. I still talk to her and I hear the answers, but it's not so strange, only because when she was alive, the last year of her life, she lost the power of speech. And I was doing both ends of the conversation then also. So I've just continued. Makes it a lot easier on me knowing that she's there talking to me. And I hope she's giving me the right answers anyway. But I wanted to do what she would have wanted to do with her life. And I know that she would not have wanted to continue the way she was. And that led us to palliative, to hospice care.
Mr. Waterstone, I'm wondering after watching the video, if you think back on your experience, do you think that there were signs that you could have had hospice support a lot earlier than you did?
Dr. Daly, it is so funny you asked that question, because as I was watching the video when you were going into the too soon and the too late, and I was thinking, yeah, it definitely probably would have been much more advantageous, but I don't know if we would have been ready. When she first went in the hospital, the first visit, when she couldn't move her limbs at all, and when she was in a very in a state that it was such severe decline over the way it was just a few days before, I definitely would have been wishing that's what I meant by I wish I'd seen your video before. Yes, I think she would have probably had at least a month, maybe 6 weeks of hospice instead of the week that she did have, because she was showing signs, and I don't blame anyone the way it went down. They were trying to treat the infection, thinking that if the infection was treated, she would be able to go back to her baseline. But even her baseline at the time was fairly, it was almost her baseline, although she was going to therapy up until the time she went into the hospital. I sort of continued to, she was holding steady through some of the therapy. She was going to a specialized therapy facility in the Los Angeles area that totally caters only to movement disorder problems. And the therapists that work there all are trained in that specific speciality, so that they know how to treat people with extreme disability and movement. So she was gaining some gains, but yes, long way of answering you. Yeah, I do believe after watching your video that the entering into hospice was probably too late, and we probably could have gained more. And I wish I understood more about hospice before we chose it. I think there was a lack of communication, probably not having time maybe to really get orientated to it. We weren't thrown the word hospice until the very end, and I think it's something that should have been explored much earlier.
And I thank you for sharing that. I think that's probably a fairly common experience that people have in terms of people in general throughout their regular lives are not necessarily exposed to hospice care, except kind of on the periphery. And healthcare providers often are either uncomfortable bringing it up or bringing up end of life issues, or don't actually know, because I think that's a surprise to people too, is that especially in neurologic illness, there's not much education for trainees in providing neurologic care on signs of end of life, how to continue to provide care through end of life. And unfortunately, and this is not universal, but it's common that people are just not getting like practical information from their care team as they're facing different problems. And then this is a story that I keep hearing people tell me, is that they were kind of down in the weeds in problem solving mode, and you kind of go from solving one problem to the next problem to the next problem. And unless someone, whether it's, family member involved or a healthcare professional involved, someone triggers taking a step back and looking at the overall trajectory over time, and taking a step back and looking at the big picture, then you kind of miss those inflection points of being able to get more care. I think this is something that Parkinson's Foundation and the International Palliative Care Society are really working on, trying to change and improve in the healthcare system.
Dr. Daly, What would you say, how important would it be to plan early and have these discussions with loved ones and family members about end of life? Maybe you could share some signs of what end of life is, but most importantly, how important would it be to have these conversations early on so we're not riding the roller coaster and we can be present for these moments, these last few moments of a loved one?
Yeah, that's a really important point. I'm glad that you brought that up. I think that it's always, these situations are generally under a lot of pressure. So if you're trying to explore what somebody would want or think about what somebody would want at the end of their life, at the same time that you're trying to make a healthcare decision, it can be just information overload and too much to consider all at once. So whenever it's possible to have conversations about what the end of life might look like and how ideally it would be, it's always better, if possible, to remove the stress from the situation and have it just be a hypothetical conversation before you're in that moment, because that's when people are really able to share. Pile on top of that usually at the end of life with Parkinson's disease, people have difficulty communicating or have significant cognitive impairment. So it's possible that the person who's being cared for is beyond the point of being able to contribute to their decisions. And you're really having to go back and think about what they expressed in the past. Early conversations are so valuable. I don't want to say everyone, because I feel like this is changing, but the great majority of people avoid such conversations, even though they're so important. And but it's super helpful. And the families that I work with who are the least stressed and the most confident in their care of their loved one at end of life are people who really feel confident that they know they're fulfilling their wishes. And it's usually because they've talked about it before, or they had a prior experience in their family before where they had an opportunity to learn from that experience and know what they want to do differently the next time.
I'd like to interject something that there's a sort of an adjunct that goes right along with this. Fortunately, Judy and I, at my insistence, I noticed when she still was cognitively totally with it, as maybe the wrong term, but totally able to make decisions and express our beliefs, we totally revised our estate plan. And that was an essential, because at that time she let it be known exactly what her wishes were. So I did have that knowledge going in, which it's interesting because I was discussing this with our doctor, and I mentioned to him what I had just discussed before, how Judy had told me what she wanted if things ever really got terrible. And he said, well, the decision has been made for you then. You've got a really easy position because you know what your wife wanted. As a matter of fact, you're not even right now in the driver's seat any longer. You have to obey your wife's wishes. But the only reason I knew her wishes was because we had revised our estate plan so I knew exactly what she didn't want and what she did want. So therefore, something like that is another way of looking at this from sort of the back angle of it, going in and realizing that, yeah, it is important to know what your plan is. And it's a hard thing to discuss, but it's something, particularly when you're in my age bracket or our age bracket, it certainly is something that you should gain full knowledge of because it's essential.
And Stuart, you alluded to a message of communication between you and your wife. And so I know that this was in our previous conversations a real theme, and one of the things that you hoped to share with our community today was centered around communication. Can you talk a little bit more about the importance of communicating, not only that you and your wife had these conversations, but various conversations with the professionals involved in her end of life?
Absolutely. Krista, thank you for noting the importance of that too. Looking back on it, I think it covered everything. It covered the communication, obviously, between my wife and myself, communication with our family, because our family is a very close one and we needed to all be on the same page, which we were. But communication with the professionals came in all through the entire gambit of treatment from the time she was diagnosed with Parkinson's until she did pass away. But looking at specifically as it associated with going into hospice, the communication between the people who provided this service should have been, it sort of was I felt like it was rushed. Suddenly we went from having her in the hospital, and then suddenly the SNAP comes about. The discharge planner is the person who discharges you from the hospital. They suggested the company. We went with the company. Then there was, the next thing I knew, I was visiting her and I had to be home within 20 minutes because they had to deliver the specialized bed. And I said, there's no way I can do that. Then even to the point of where there was a real snafu as to some of her pain medication at the end that was needed, but it was running out because we didn't know that it was a mix-up, because I received simultaneously two deliveries, one from the company and one from Amazon.com. And I didn't realize that the two, and I just put them aside and didn't even realize there were two there. And we were totally, completely disjointed. I wasn't sure what they were trying to do. The company was telling me they could be there, they couldn't be there. Immediately, the nurse was coming, maybe they needed a different nurse. All of this communication was not there at that particular moment. And then walked in the angel, who was the nurse who was with Judy until Judy passed away. And she immediately, it was funny, you talk about communication. She said, guys, I need to talk with you in another room. She says, you all got to calm down. She says, your wife understands, your mother understands everything that's going on. You're making her more tense. I know you're tense and you have a reason, but you have got to have 5 minutes here. I'm not going to let you back in the room for 5 minutes. I want you to all reach a very calm state. I will take care of it. I'm in charge. There will be no longer any problems. I promise you. And that's the way it turned out. I mean, this lady was a gift from heaven, even to the point where she, as you told us, Dr. Daly, not only can you not predict how long you're going to be in hospice, I don't think you can even accurately predict exactly when the person's going to take their last breath. And she told us, she said, your daughter, it's time when your daughter, who was in Chicago at the time, Rebecca is our daughter. She had come out and was with me for the entire week, the last week that Judy was in the hospital. She had to go home to get some things done. She also has 2 minor children. They needed to go back. And by the way, the one thing that the hospital care, when you talk about communicating again, I communicated to them, it's against the rules for any children to see a patient in the rooms. I think it's like 18 or 16, whatever they have their age limit. And we have 2 grandchildren, one who was 9, one who was 6. And I felt like they were in California visiting from Chicago. And I explained it to the 2 charge nurses, both evening and day. And what they did was amazing. They cleaned Judy up, they cleaned the room, they made it incredibly not at all threatening, and they arranged for our 2 littlest grandbabies to be able to say goodbye to their grandmother while she was alive rather than after she was alive. And she perked up a little bit when she saw them, when she knew they were there. So they actually did get to see her. And it was, again, communicating to the hospital staff, or the 2 ladies, how important it was for both sides. And that indeed went on. But once again, getting back to my daughter being back in Chicago, I don't know how our son-in-law did it, but having the advanced knowledge, and this was one of the benefits or one of the good parts of hospice care, getting that accurate prediction. Within 8 hours, my daughter joined us and was able to be here to be with her mother when her mother passed away, as our entire family surrounded her. That would not have happened if hospice care wasn't there, because we would have never known exactly when to bring Rebecca out here. Now her husband arranged from Chicago. 8 hours later, she walks into the house, and you got to factor in the 2 hours at the airport plus the 4 hours of the timing of the flight. And then you got to add in the traveling on the San Diego freeway, which we've already discussed at rush hour, which was bumper to bumper. But Rebecca walked into the house and was there Judy didn't pass away till the next morning, but it didn't matter. She was there, able to be, we were able to all be together, which was extremely important.
And that sounds like a stellar nurse who really did what needed to be done in the moment. It's I'm so glad that they got to that point. I think that what impresses me when I hear the rest of your experience is that it's that hospice experience of crisis mode, of being already relatively close to the time of death when hospice is getting involved. And so like there's a lot that has to happen with equipment and meeting people, and they're trying to cram it all in. And at the same time, you're trying to be present with your, person who is ill. And I think that, sometimes it has to be that way. Sometimes there aren't warning signs and people don't realize until the end. But when there are some gradually accumulating warning signs, like losing weight, losing function, having repeated infections, when some of those red flags are popping up, I think that's why it's so valuable for people to recognize it, because you can imagine how different that experience is. Like if you're at home and they're not in the middle of a crisis and you're signing up to have the addition of hospice care, then you have the ability to, they're going to call and say, we can deliver a bed later today. And you can be like, I'd rather if you came tomorrow, because I'm busy right now, and you don't need it right that second. So it's okay.
Exactly.
And there's so much more control and less stress. And again, it's not always possible. Like sometimes it's just a whirlwind, and the situation means it has to be that way. And that is what it is. But there are other times where the signs are there. So, we're in the neuro-palliative care world, we're really trying to educate more and more general providers and neurologists about end-of-life care, and end-of-life care providers about neurologic illness, so that people are better able to communicate when they see these signs happening and bring it to a family's attention in a constructive way.
And I also think I agree with everything you just said. And looking back in hindsight, I can see where so much of that was there, and it would have been easier if it had been a smoother transition, because time is your enemy in certain events. And when I want to reflect one more thing about the communication, even between the communication for the hospice physician and us, was, I think, skewed. I think she misinterpreted what we were wanting for Judy, because when she came on the scene, she decided to re-implement a failed protocol that hadn't worked for, it hadn't worked for like 20 days of giving Judy antibiotics. And she decided, let's try a third round of it to see if suddenly there is some, I don't know whether we were hoping for a miracle, but I think what in essence she really was doing, and I don't think she realized to us that was not our objective. I don't think our objectives were clearly on the same path, was that Judy would not pass away on Thanksgiving, and keep her alive through the Thanksgiving weekend, so to speak. And to be honest with you, Thanksgiving, which had always been Judy and my favorite holiday, so maybe the way it happened was some omen of some sort, but the fact that Thanksgiving wasn't at all relevant to us at all. We were only interested in how keeping Judy comfortable and doing what was best for her, and had no relation at all to the holiday. But I think to this lady, to this physician, I think it was her intention to make sure that Judy made it through Thanksgiving, and she didn't anyway. She actually passed away Thanksgiving morning. Being we were all together anyway, we had a small Thanksgiving dinner, just our immediate family, which was,
That's really beautiful.
I mean, the way you described it, Krista, very well in our initial conversation. It made death is never pleasant, obviously, and you lose someone that's been such an integral part of your body that they become part of you. And my kids very close to their mother, and if it can be a beautiful experience at all, the being we were all there and able to hold on to each other and hold Judy at the same time made it much more. It turned a situation that could have been horrible into a much more acceptable solution.
There's this polarity in going through the process of grief. Grief isn't just a feeling, it's a process. And to feel gratitude in light of Thanksgiving that the family's together in a time of sadness and loss is really quite beautiful to be able to experience together. So thanks for sharing that.
It's
Yeah.
totally true.
I also appreciate your sharing that. I think that a lot of times when people discover that I'm a professional working in end of life care, that people's initial thought is like, oh, how could you possibly do that day in and day out? And as a professional, I would say that I see a lot of beauty in end of life care. I see a lot of difficulty too, and I see a lot of difficult things. But providing expert care through the end of life helps some of those beautiful moments happen, and that's why I do it.
Dr. Daly, we actually got a question from one of our attendees that's right along these lines. And they wrote, I have a difficult time getting my family to understand that hospice was not the same as withdrawing care and letting my father die. Can you address this for other people who may be having the same challenges?
I think that's a great question to share. It's certainly a common feeling that people have, that the idea that hospice might be giving up. And I, as a hospice professional, I actually, I try to make a conscious decision now when I'm speaking about hospice that I don't say refer to hospice or send to hospice or anything like that anymore. I'm trying to remove that from my language entirely. And instead I say add hospice support, because that's really what I'm doing. Hospice is supposed to be about adding resources, giving more care in a difficult time, providing more equipment, providing more attention at home, providing more hands-on care, and not about taking anything away. I mean, we did in the video, I talk about a few specific instances of trade-offs. So they're there and they're real, but in general, the overall concept is that hospice is supposed to be adding care. And I'll start to ramble. Hospice is supposed to be about adding care, period.
Is there a difference between at-home hospice care or receiving hospice care through, say, a center or a facility?
Oh, that's a great question. Yeah. There's the great majority of hospice care, like 85 to 90% of hospice care in the United States is provided in people's own homes. And so it's most commonly the hospice team coming to where the person lives and doing intermittent visits to enable a family to continue to provide care, not taking over, not doing everything. There's still a lot of work for the family to do, but making care at home possible when it otherwise might not be possible. So the great majority of the time, hospice is coming to where a person lives. There are much smaller percentage. There are hospice inpatient centers, which are basically like hospice hospitals. So they're places where very high intensity level of care at the end of life can be provided, type of care that requires continuous injectable medications or other high level medical supports that really require a hospital setting, but with a focus on comfort. So there are hospice inpatient centers that are relatively limited in number. And then there's even smaller in number residential hospice, whereas someone can actually like go to live in a hospice facility for months until the end of their life. And that, at least in the DC, Virginia, Maryland area, that's extremely uncommon. So hopefully that makes sense. When you are adding hospice support, your physical needs are what determine that difference in care setting, as well as what resources are available in your community.
Thanks, Dr. Daly. And being mindful of the time that we have left, I'd like to kind of round us out with some key takeaway messages. And I'd like to ask you, Dr. Waterstone, as a care partner for someone living with Parkinson's disease, and having lived the experience of hospice care, how did this impact you? Your wife being enrolled in hospice care and receiving it, you as an individual, how did hospice care impact you?
Well, first of all, as I've alluded to before, it definitely enabled our entire family to be together at the end, which was probably the most important thing looking back. It also, I don't know what would have been any other treatment or any other way Judy could have died peacefully and calmly and in her own setting, her own family setting. It gave, if she had gone into a skilled nursing facility with something that she never wanted to do, it would have been extremely taxing on myself, on my kids, on everyone. At least she was in her own home. I mean, this was incredibly important to Judy. Everybody, I mean, so many people have said to me, you actually fulfilled your one thing that you said you always would do, to try to get Judy to die within her own surroundings and having her whole family around her. And that could not have happened without hospice. And again, many thanks to the nurse who I guess gave Judy a beautiful exit rather than making it a harsh one in a facility where she could have been alone, because you can't, in a facility, we couldn't have been with her 24/7. It could very easily have been that she would have been totally alone when she passed away. And I know that's something that, frankly, I'm afraid of. I would like to think one day that when I go, that my family will be around me. It's a different way of going. So the hospice care did that. And it did enable us to be with her for that last quality moment.
Not only offered your wife comfort, but your family and you as well.
Totally.
Thank you, Mr. Waterston. Appreciate you sharing your story and your experience through, the darker side of life, but also finding some beauty behind it all too.
Thank you for the opportunity.
Dr. Daly, in closing, I want to be sure that our community here present live and those of you who will be watching the recording later on, what are some of the key takeaways or next step action items that, after receiving this meaningful information about hospice care, what are those pearls that you would offer in closing?
I would say a few different sort of next actions depending on the situation of the people listening. So there might be some people listening who, when they saw the video, actually recognize some of those signs that I described, and that maybe no one has been talking about it, or no one kind of putting it together as a big picture. And to those people, I'd say bring it up with the healthcare professional that you're closest to. So that maybe your neurologist, it may be your primary care physician, but I would say bring up the possibility that you're seeing some of these signs like weight loss or infections, and can they put together what it means and what you should be thinking about. To those people, don't necessarily rely on the healthcare professional to start the conversation, because now you might be more educated than they are about certain things. To people who are hearing this as more of a theoretical thing to be aware of for the future, I suggest getting familiar with what hospice resources are in your community. It's many communities have more than one hospice organization, and they have different reputations, and it's just good to start talking about it. Start talking about what experiences people have had in your community, so that you're aware and knowledgeable about what resources are out there. And I would also say start talking to your neurologist about if they have close relationships, or if they're considering developing a relationship with a hospice provider, because that advocacy about information sharing between end-of-life care providers about neurologic illness, and for neurologic healthcare providers about end-of-life care, that bidirectional information sharing is so important right now. And so I guess the summary is start talking about it, start talking about end-of-life care kind of in all settings. And you'll be a grassroots advocate, even if you're not planning on it.
Right. The message I'm hearing again is to communicate with your loved ones, with yourself, and with your healthcare professionals. Keep talking about it. So thank you, Dr. Daly and Mr. Waterstone. Appreciate you both sharing your time and experience and expertise with us in this very, very informational session on palliative care. On
Thank
behalf of the Parkinson's Foundation, many thanks again to you, Dr. Daly and Mr. Waterstone, and many thanks to all of you who've joined us today. A follow-up email will be sent with a survey. Please tell us what you thought about today's program. You'll also receive a link to today's presentation with additional resources in the coming days. Join us for the next Wellness Wednesday. We will return to our expert briefing series on understanding gene and cell-based therapies. While still in the developmental stage, genetic and cell-based therapies hold some promise for people with Parkinson's disease. This webinar will review what those considering gene-based or cell-based therapy may expect in terms of symptom management and disease progression. You can learn more and register for our PD Health at Home events at parkinson.org/pdhealth. If you had a question today that was not answered, please reach out to our helpline by calling 1-800-4PD-INFO or emailing us at helpline@parkinson.org. You can use that same contact information to order our free resources. We thank you for joining us today, and we hope to see you soon in the Zoom land world again. Bye for now.